All right. Good afternoon, everyone. Thank you all for joining us for our webinar today. My name is Melissa France. I'm a project coordinator here at Fight Colorectal Cancer. We are the leading patient empowerment and advocacy organization in the United States. We provide balanced and objective information on colon and rectal cancer research, treatment, and policy. We are relentless champions of hope, focused on funding promising, high-impact research endeavors while equipping advocates to influence legislation and policy for the collective good. We are here today to recap ASCO 2023. And for those that don't know, ASCO is the American Society of Clinical Oncology. And every year they hold an annual meeting, and it's one of the most important conferences for presenting the latest, most practice-changing research in cancer care. Before we get started, I do have a couple of housekeeping items. We are going to have some time at the end of the webinar to allow for questions. If you do have a question, feel free to put it on the right side of your panel in the Q&A section, and we will do our best to address those at the end. We will also have a recording of this webinar available on our site. As registrants, I will send the link directly to you via email. So look for that in the next couple of days. And last, feel free to tweet along with us. You can use the hashtag CRC webinar. And with that, I would like to introduce our two presenters for today. We have with us today Dr. Cathy Ng, as well as Julie Krause. Dr. Ng is a highly sought after and respected doctor in the colorectal cancer community, especially in the early age onset community. And Julie Krause is one of our research advocates. We are so honored and fortunate to have you both here with us today. And with that, I'm going to pass it to Julie to go into a deeper introduction of herself.
Hi, I'm Julie Krause. I have been a member of the RATS Research Advocates in Training now since 2016. So I've been at this for about 7 years now. Currently, I work with the Alliance for Clinical Trials, which is a cooperative group with NCI. There are 5 cooperative groups in the United States, and these are primarily what we work on are investigator-led trials, as opposed to trials that come from pharma, drugs that they are coming up with. I've worked with the DoD, other organizations. I work with NCI on accrual trials that have problems accruing. And I am forever learning more about colorectal cancer. And it just seems to be just a never ending, there are always things coming out in colorectal cancer research, and it's just so interesting to follow along with them. And ASCO represents a wonderful opportunity for patient advocates, research advocates, doctors, and anybody associated with cancer in the healthcare field to come together and really learn about what's new, what's come out in the past year. So it's a big conference. Brings people in from all over the world. I had heard over 40,000 people came in for ASCO here in Chicago at McCormick Place. I was very honored to be selected to go to ASCO this year and represent Fight CRC. There's so much excitement around the abstracts and posters and the presentation. The hopeful spirit is just very contagious. It's very interesting to go to the presentations and hear cutting edge knowledge about treatments and technology that's coming out. Hearing the questions that are proposed during the presentation panel further expands on the experience. Just brings out and highlights some things that you might not have realized were as important as they really are. Walking the exhibition floor never ceases to amaze me. I mean, it is just the booths and the people that are there representing their organizations, whether they are pharma, patient advocacy organizations, payers, they're from all around the world. So it's such a neat opportunity to see not only what we do in this country, but what other countries are doing as well. And you wouldn't really get that anywhere else. Let's see. I did learn quite a bit of I did learn information that I am hoping now that I can pass on to that I work with here locally in my local community. And last but not least was the opportunity to get to know some of my fellow rats a little bit better. We see each other on calls and once in a while we have rats meetings where we get together, but this was really 3 days with 3 rats that I work with, and it was a really neat opportunity to get to know them in a way that I would not have known them before. So that's a little bit about me, and I'm looking forward to hearing what Dr. Eng has to say about some of the abstracts that were presented at ASCO 2023. And so now I will introduce Dr. Eng. Dr. Eng, if you'd like to present your abstract reviews, and I will let you know about the questions and answers afterwards.
So I'm Cathy Eng, and I was asked to give this discussion about some of the specific abstracts at ASCO. I'm a professor at Vanderbilt Ingram Cancer Center, and I'm the GI program leader for clinical trials as well as the GI research here. I'm also the co-chair of the NCI GI Steering Committee. I'd like to thank the organizers for asking me to speak. We will try to focus on some of these abstracts as best as possible, and in full disclosure, some of these slides are actually relatively new to me as well. So please, we'll be sharing this information together, and hopefully we'll have some take-home points. So let me want to make sure I have the right one. I think this is it. Okay, can you guys see everything okay?
Yes.
Okay, perfect. There's my contact information below for both. I'm primarily on Twitter. I do a little bit on Facebook. I don't have as much time to spend on all the various social media sites, but I'm very engaged with social media, as many of you may be aware. So these were the 6 abstracts I was asked to discuss, and we just added on a 7th one just shortly, which was not from ASCO, but is from ESMO, and that's because there is a paper that is coming out tomorrow night, and we hopefully will have a new drug approval before the end of the year this year. So we'll be starting off with the PROSPECT trial, and the PROSPECT trial is a study that I was involved in earlier on in my career when I was at MD Anderson Cancer Center. This trial took about 10 years to come to fruition and to be completed. And this was led by Dr. Deborah Schrag. And this was actually the plenary session at this year's ASCO meeting. So what is the purpose of this trial? Well, the purpose of this trial, as many of you are aware, is that the standard of care previously had been by providing combined chemoradiation therapy before surgical resection for our rectal cancer patients. And obviously, trials for rectal cancer are extremely important, especially for our early onset patients, just because they are more prone to be developing a rectal cancer, at least based upon the data we have, as well as left-sided tumors. But for the purpose of this discussion, we'll be focusing on the rectal cancer patient population. And historically, following surgery, we would provide patients post-operative chemotherapy or adjuvant chemotherapy. The reality is that there are patients that anywhere between 25 to 40% approximately that may never receive adjuvant chemotherapy. And so more recently, we've been changing this thought process and moving this chemotherapy more upfront. The sequencing is a different story, but basically historically, for these locally advanced patients, total neoadjuvant therapy has become quite popular and has been well adopted by many individuals. But the purpose of this trial was, once again, the enrollment was from 2012 and 2018. It was specifically for node-positive patients or T3N0 patients. And what does that mean? Well, node-positive obviously means lymph nodes that are involved locally without distant metastatic disease. And then T3 is the degree of muscle tumor penetration through the muscle layer. And patients were randomized in a 1-to-1 fashion to standard chemoradiation therapy or the consideration of FOLFOX. And the thought, once again, is how can we change this kind of sequencing? So this is the official study design of Prospect. So the top arm is basically the control arm, which was the standard of care at that time, and it still is the standard of care at many for many patients. And here is the investigational arm, or the intervention arm. So patients would receive 3 months of FOLFOX-based therapy or oxaliplatin-based therapy. And at this time, the use of oral Xeloda with oxaliplatin was not very popular at that time. Obviously, this has changed with current treatment approaches. But at that time, everybody was offered all IV 5-FU and oxaliplatin. If they when they were evaluated by CT scan, if they had greater than 20% response, the consideration is, are these patients that can potentially avoid radiation therapy? If there was less than 20% response, obviously, or just stable disease, then patients proceeded to go on to standard chemoradiation therapy. So basically, they would go this standard approach. And then there was a little bit of leeway in regards to utilizing IV 5-FU or capecitabine during the radiation treatment, as well as the type of radiation treatment. And then not everybody has a dedicated radiologist for pelvic MRI prior to surgical resection. So we did take that into account. An open or laparoscopic surgery was up to the discretion of the surgeon. So once again, it did not include T4 patients. So T4 meaning that it was involvement of either an adjacent organ or perforation. These were patients that were candidates for sphincter sparing surgery, meaning those candidates that didn't necessarily have low-lying tumors, because that would often result in loss of sphincter preservation. But these were tended to be tumors that were mid to high lying. So those that were usually 5 centimeters or greater above the anal verge. And once again, these were not including T4 patients, meaning new encroachment upon another organ, or patients that would end up potentially losing their sphincter. And I'm not going to go into the statistical design, but basically the top limit of what they wanted to achieve was 1.29 for non-inferior design, meaning that they wanted to demonstrate that the omission of radiation therapy would be non-inferior to receiving standard chemoradiation therapy prior to surgical resection. And this was a study patient population, and we always like to show this to demonstrate that patients overall were fairly equivalent between the two arms in regards to the participants that participated in the clinical trial. And this was the primary endpoint. And I'm sorry, I thought I had another slide in here. I may have accidentally omitted it. You know, obviously the purpose of omitting radiation therapy is because of potential adverse toxicities that are associated with radiation therapy, which include sexual dysfunction, urinary dysfunction, and obviously bowel dysfunction. So that was the primary purpose of this study. Is there a reason to potentially omit radiation therapy so patients could have less impact overall in regards to chronic toxicities, and also that would impact fertility preservation as well. So here, after median follow-up of 58 months, they managed to demonstrate that they fulfilled their primary endpoint, that neoadjuvant or 3 months of FOLFOX prior to FOLFOX-based chemotherapy prior to consideration of surgery is reasonable in this patient population, and it was non-inferior. And this basically just shows you the bar graph that demonstrates that it clearly met the non-inferiority statistical design. In regards to freedom from local recurrence, sorry, I need to move this because this is in my way while I'm talking to you and it's cutting off my slides. Let me see if this will move up. Sorry. The overall survival was also non-inferior in regards to the primary and the secondary endpoints. In regards to the pathologic specimens, the complete response or complete with no evidence of residual disease was equivalent between the two arms. And in regards to toxicity, these were the original toxicities that were noted. And obviously with some chemotherapy, there's a potential risk factor for loss of appetite and fatigue. These are symptoms that are commonly noted, I think, with chemotherapy administration within the first 12 weeks of treatment. But at the end of the day, at 12 months, so 1 year later on, the main difference between the two arms was that there appeared to be increased neuropathy in the chemoradiation arm. And obviously that is because most patients receive their treatment in the adjuvant setting following completion of surgical resection. So here, basically, we're splitting up your treatment, 3 months of FOLFOX, evaluation, surgical resection of greater than 20% response, and then the addition of adjuvant chemotherapy or postoperative chemotherapy was at the discretion of the treating physician. In regards to quality of life, it was not statistically significant overall, but obviously in regards to, and blue is the investigational arm here. And as you can see, bowel function and sexual function were in favor of the consideration of neoadjuvant FOLFOX-based therapy, but overall not dramatically different. But you know, for a patient, this makes, I think, a big difference overall. So just to reiterate, this was not for T4 tumors, this was not for low-lying tumors, and not all patients required MRI staging, which is considered now as standard of care versus when this trial was initiated in 2012. Okay. So I think what we're going to do is move on to the next abstract, and then obviously we'll take some questions at the very end, and we want people obviously to provide us comments and questions, and I'll do my best to try to answer them, and I'm sure Julie will assist as best as possible as well. So the other trial is the PERDUGE 23 study, which many of you are aware was already presented, and this is just long-term follow-up. So this, I'm sorry, let me go back here for a second. In regards to this trial, the PROSPECT study, one thing I think it's important to understand is that, you know, how can we incorporate these findings into our current treatment paradigm? And I think the reality is there are those patients that would prefer to potentially omit radiation therapy because we know there's potential adverse toxicities associated with treatment, such as sexual, bowel, and urinary dysfunction. So if you have a mid to high lying tumor, I think this is a good way to potentially discuss the role of omitting radiation therapy. Now, keep in mind, this is not for, you know, bulky lymph node involvement. This is not for T4 tumors. And all of these patients all went to surgical resection at some point. There was no watch and wait approach as part of the study design when it was originally initiated. So I think it's very important to keep in mind. I'll show you some additional data. Is it cut and dry that we know exactly which patient population will fit in each category? Not necessarily. A lot of it will be dependent upon discussion. A lot of it will be dependent upon objectives, whether or not you are considering, if you're interested in a watch and wait approach or active surveillance approach, as some prefer to be to call it. It's just written in a lot of protocols that way, so I apologize. Versus those that are thinking more about, you know, fertility preservation, etc. So it depends upon where the tumor lies anatomically. It depends upon the degree of lymph node involvement. It depends upon the T stage, etc. So please keep that in mind when we move on to the next abstract. Okay, PERDUGE 23 was presented by Terry Conroy, which was an update. FOLFIRINOX, as many of you know, is a standard of care chemotherapy regimen in pancreatic cancer, and as well for our metastatic colorectal cancer patients. It could be a potential option for patients. This trial was a 7-year update regarding disease-free survival and overall survival. So for those of you that may not be familiar with this, this was the original study design, and I wanted to highlight this. This is a different patient population. So this is not total neoadjuvant chemotherapy because not all of the treatment was up front. So actually this is a bit misleading, and this is his slide, so I apologize, but it's not necessarily total neoadjuvant therapy. Second of all, it involves a T4 patient population. So these were more higher risk patients. And it did not matter where the tumor was located. They did not base it upon if you were high lying or low lying, although they looked at those factors later on. Once again, the control arm was a standard control arm at that time. Here, they provided 3 months instead of FOLFOX, like the Prospect trial. They provided 3 months of FOLFIRINOX. And is this a regimen I would give my elderly patient? The answer would be no. I'd be very fearful of trying to provide FOLFIRINOX, which can be very difficult for a very healthy young patient, even. So 3 months or 6 cycles of oxaliplatin, irinotecan, and 5-FU. So the entire kitchen sink, excluding a targeted agent such as bevacizumab or an EGFR therapy. So full systemic chemotherapy regimen, and then chemoradiation therapy, and then surgical resection. And all patients were required, unlike Prospect, to receive adjuvant chemotherapy following their surgical resection. Okay, these were the characteristics of the patients. And these were, once again, very few of them were high-lying tumors. The majority were mid to high-lying. The majority of patients did not have T4 disease, but were mostly T3 disease. But all the patients had node positivity in this setting for the most part. So in regards to updates, the cumulative incidence of recurrent disease, so in red, is the investigational arm. Once again, I do not favor what they call total neoadjuvant therapy here. This is not TNT from my perspective, because there was still chemotherapy provided after surgical resection. But you can see here in regards to local recurrence, less likely, slightly less likely with local recurrence, and less likely metastatic disease. And these numbers we'll show in just a second. So in regards to disease-free survival, and I think my landscape is going to be out front, so I hope you guys can hear me still once it gets initiated. So the 7-year disease-free survival was a difference roughly of about 5% between the standard care arm in favor of the investigational arm with FOLFIRINOX. This is a little bit less than what was reported originally at the 5-year disease-free survival rate at its original presentation. In regards to metastatic disease-free survival, once again, in favor of the FOLFIRINOX arm, a difference of roughly 74% versus 65%. And that's pretty comparable to what was reported earlier, which is about a 10% difference. And in regards to cancer-specific survival, it was 85% versus 80%. So a little bit difference, about 5%. And not much difference, because this is about 6% difference as reported earlier in their analysis. In regards to overall survival, the overall survival is slightly less than what was originally reported, but it is still 82% versus 76%. So after a prolonged follow-up, basically induction chemotherapy, I think this is more appropriate terminology because it's not total neoadjuvant therapy. Induction meaning that it is provided prior to radiation therapy. It does appear to improve the overall survival of patients. And in regards to disease-free survival and metastatic disease-free survival, that appears to be what is most noticeable in this setting. And once again, this is a very different patient population than what is reported with Prospect. And this is not all total neoadjuvant therapy. This is induction chemotherapy prior to an evaluation with chemoradiation therapy, followed by surgery. And then all patients received additional chemotherapy following surgical resection. Okay. Julie, do you want to, is it okay if I just continue to proceed? I see a couple of questions, but is it okay if I proceed?
I think it's fine if you proceed. I think that either way, if you want to answer the questions as they've come up now, or you want to wait till the end, works for me.
Let's try to go through the whole presentation first, and then we'll leave time for Q&A then, because then that way I'm afraid if we do all the questions in between, we may run out of time.
Perfect. Thank you so much.
Thank you so much as well. Okay, So OPRA, as many of you may be aware, is the original trial from Memorial Sloan Kettering Cancer Center. And also, once again, a different patient population here as well. So this is long-term results of the phase 2 analysis of OPRA. And OPRA was originally only completed at Memorial Sloan Kettering Cancer Center, as well as, I believe, 16 selected sites that participated in this trial. So this trial was looking at, originally they like to call it watch and wait approach or active surveillance approach. And this is, I'm so sorry. And the investigator only provided this poster, so I apologize. I'm hoping you can still see this. If you blow it up, he didn't have individual slides. But this was what was specifically for low-lying tumors. So these were high-risk patients with low-lying tumors that weren't necessarily being considered for sphincter preservation. And what was different about this study is that the control arm is they were just comparing it to historical controls. The investigational arm was really looking at the sequence. Are you better off looking at chemotherapy first, or are you better off doing chemoradiation therapy first? And that's kind of the take-home point of this analysis of OPRA. There is another study that I should have included a slide for. It's an ongoing study, and we can talk about it in a little bit. But this is after a median follow-up of 5 years, and this is a small study, obviously, because it's a phase 2 study of about 324 patients. And the main thing is that in regards to organ preservation, once again, these are for low-lying tumors, you were better off receiving concurrent chemoradiation therapy first before receiving the chemotherapy, before any consideration of surgical intervention or active surveillance approach if you're thinking about sphincter preservation. So that's what is noted here in regards to organ preservation. In red is the concurrent chemoradiation therapy arm. In regards to disease-free survival, actually they were equivalent in regards to the sequence. So it's not the sequence that's impacting disease-free survival, it's the sequence that's impacting the consideration of active surveillance for sphincter preservation. And then disease-free survival after surgical resection for those patients that needed to go on to surgical resection, the majority of the regrowths or reoccurrence of disease was at 2 years. They were primarily within 3 years of restaging. So organ preservation is feasible in select patients, but once again, keep in mind, these patients were followed rigorously with MRIs, CT scans, physical examination, colonoscopies, etc. And this is really a team approach in order to consider sphincter preservation. And obviously for our young onset patients, sphincter preservation would be extremely important, I would presume, obviously because of the consideration that you may end up with a permanent colostomy for a low-lying tumor otherwise. So this data has now resulted in the creation of the Janus trial, which is a little bit of the Perdige as well as this. So the Janus trial is open up nationwide, and that is a very large phase 2 study looking at the role of FOLFIRINOX as the total neoadjuvant chemotherapy regimen. And in Europe, they are looking at sphincter preservation in their own clinical trial. But here in the United States, we have the Janus trial, which is open. Oops. Okay. Moving on to metastatic colorectal carcinoma. This is a very small phase 2 study, is for a very select patient population. So TDX is a drug that's approved in gastric cancer and breast carcinoma. We saw some very interesting data from the Destiny-1 trial. This is the results of the Destiny-2 trial, which is focused on dosing. And this was presented by my former colleague, and I've had the pleasure of mentoring Dr. Raghav when I was faculty at MD Anderson. So this is a very select patient population. So these are patients that are HER2 positive. So that represents less than 4% of all of our metastatic colorectal cancer patients. They were allowed to be RAS wild type or have a mutated tumor. Patients were required to be BRAF wild type. They had to have good performance status of 0 to 1. And basically, what was looked at here was dosing. So is it a 5.4 milligram dose or 6.4 milligram dose? And both are given every 3 weeks. And it is not necessarily powered to compare the two arms, but was basically just to get an idea about what is the response rate between the two arms? Is it equivalent? And what are the toxicities? So TDX or deruxtecan is an antibody drug conjugate, there's a lot of interest, and I'm not going to go in depth regarding what type of how this drug works, et cetera, because in the interest of time, but also because that is not new information regarding antibody drug conjugates. I want to focus on the current information, and in this case, it will be about how what dosing will be utilized to move forward. So these patients, the majority on examination were 3+ in regards to their HER2 status. So when we check for HER2, you have to have high expression. So either it'd be high expression by a simple study called immunohistochemistry, which can be done at almost any hospital. And in some cases where it's kind of equivocal or 2+, you have to do additional tests called FISH. Which then we have to do what's called FISH amplification, and that, oops, I am so sorry, why did it do that? And that's what this ISH is, that means FISH positivity. So the majority of these patients were 3+. So a prior study had indicated that, in fact, unlike breast carcinoma, where they've now demonstrated that if you have a low expression, you would still benefit from this class of drugs in breast cancer. However, that's not been found to be true in colon carcinoma. In colon carcinoma, you ideally should be 3+ in order to have benefit from response, or 2+ and verified by FISH amplification. And the majority of these patients were RAS wild type, and that is because we have data that has demonstrated that you're HER2 positive. These patients tend to be more resistant to anti-EGFR therapy. So then, therefore, we want to make sure that these patients, for the most part, have RAS wild type tumors. And they had some interesting data in here, which suggests that there may still be some benefit in patients that are RAS mutant, which I thought was quite interesting. Once again, small numbers though. Very common in HER2 positive colon cancers, these tend to be left-sided tumors as demonstrated here. And once again, the majority of patients were 3+ and RAS wild type that were evaluated. So the primary endpoint was response rate. And you can see here, these were heavily pretreated patients, previously treated patients, for 3 to 4 lines of therapy. They had received all the standard typical regimens. And some of them had received even prior HER2-based therapy. And that's what was unique about the original study design, is that this drug works specifically in patients that may have been already exposed to HER2-based therapy. And this is the primary endpoint. This is looking at response rate. So for the lower dose of 5.4 milligrams per kilogram, you can see here the response rate overall was about 45% for all patients, but for stage 1, specifically in the first 40 patients that were enrolled, it did go down a little bit to 31%, but the total patient population was 38%. And for the higher dose, they actually didn't seem to derive any increased benefit of response despite a higher dose. And the median number of cycles, as you can see here, is between 7 and 8. In regards to progression-free survival, which is the secondary endpoint, you can see here fairly comparable, slightly higher in progression-free survival. For overall survival, it had not yet been reached in the higher dosing, but 13.4 months in the 5.4 dose. And this is basically the change in response. And as you can see here, there's even quite a few patients that had stable disease. So I think that's important to note. So we have this cutoff. You'll see this a lot in the slides that we show. And that is because minus 30% is what protocol is required to go by what's called RECIST criteria when we measure. And we measure based upon the number of the greatest diameters. And we're only allowed to measure 3 lesions per organ. And in order to be considered to have a partial response, you have to have at least a 30% response rate. And that is what this dashed line is. Everything in between is considered stable disease, though. As you can see here, there are some patients that are very close to having a partial response. And there were a couple of outliers that obviously had a complete response. In the RAS, these cones are patients that were not RAS wild type, but that were RAS mutant. And as you can see here, there are, once again, some patients that were responding despite the 6.4 dosing. So once again, the increased benefit of response was predominantly in your RAS wild type patient population, but there were some that were RAS mutant that did respond to therapy. And I think that does open up the possibilities that not all patients can be put in one category, and that not all patients, despite being HER2, which historically suggests you're supposed to be resistant to EGFR therapy. So ideally, you would want a RAS wild type patient. In fact, this demonstrates there are a small number of patients in this study, at least, that had some benefit potentially from being a RAS mutant tumor type. And in regards to toxicities, the main issue with toxicities with this drug is interstitial lung disease, and there was slightly higher increased incidence in the higher dose. So the recommendation is for deruxtecan moving forward at 5.4 milligrams per kilogram. It's at every 3-week dose, and ideally I would utilize it after patients have received prior anti-HER2 therapy, because we don't know if you reverse the process and do this drug first, because theoretically the newer drugs in HER2 are not specifically after deruxtecan. So I would do tucatinib as my first option with trastuzumab, and then save deruxtecan as the second line option following progression of disease. Okay. The NeoCol trial, I'm trying to keep track of the time, so I apologize. So the NeoCol trial, I'm just going to go over very briefly, because this did not fulfill its primary endpoint, but I find it very interesting. So this was a study as presented from Dr. Jensen, who had the pleasure of interviewing. If you want more details regarding this trial, you can go to the ASCO Post website, and I had the pleasure of interviewing him regarding this trial. And so basically, this is looking at early stage colon cancer. So no, not metastatic colorectal, just early stage colon cancer. Can we provide patients chemotherapy for, so very similar to rectal cancer, can we provide chemotherapy upfront first before going to surgical resection, and does that benefit the patient? And that was the point of this phase 3 trial. And he told me he actually wrote it 10 years ago as well. So unfortunately, as you can see, it's hard to get the results you need within a quick period of time, because not enough patients enrolled in clinical trials, obviously, and it takes a lot of time to design these trials and get them open at various sites. So the staging for preoperative eligibility was based upon a CT scan, which is very difficult. So I just want to make sure that you are aware of that. There's no great way to look at the T staging or the muscle penetration preoperatively. Most of the data we have is postoperative. And so patients were either given oxaliplatin with either oral capecitabine or with IV 5-FU. Primary endpoint was disease-free survival, and his goal was basically to improve the disease-free survival by 10% from the control arm. So, oh, I'm so sorry, this kind of moved when I moved it. I apologize. But anyways, so these were, there was really no difference between the two arms. There was a little bit more that had a laparoscopy in the neoadjuvant arm. And in regards to post-operative issues, there were actually less post-op issues. Oops. As you can see here, so an ileus is basically when your bowels are not moving appropriately following a resection potentially, and it's almost causing a neuroobstruction. And then there were more increased incidences of bowel or anastomotic leakage if you were on the upfront standard of care arm. And in regards to, let's go to the data. And in fact, there was little less toxicities, obviously, in regards to neuropathy for some patients, because they probably got a full course of chemotherapy following their completion of treatment. And as a result, they had more toxicities associated with neuropathy. So once again, kind of splitting it up probably does help in reducing the toxicities from oxaliplatin. This is the primary endpoint, which was not statistically different, and the overall survival was not statistically significant. So in conclusion, I would say that it's intriguing data. We consider neoadjuvant chemotherapy prior to surgical resection an easy consideration, and would we incorporate this into our everyday treatment? I would say no. I personally have provided in select patients that have very large tumors that the surgeon would feel more comfortable, as long as there's no evidence of obstruction or near perforation, that they wanted some tumor shrinkage. But in regards to specifically disease-free survival and overall survival for all comers, this is not necessarily ready to be adapted off protocol. I think it is worthwhile considering if patients want to participate in a clinical trial, maybe moving forward, because obviously there were potentially less post-operative toxicity and less overall toxicities for the induction or neoadjuvant arm. Okay, and then I threw this in at the last minute because somebody said maybe I should mention this. This is Bong recommended, so I would like to thank her for reminding me. This was actually presented at ESMO. The reason I'm showing this here is because we have a big publication coming out in a little over 24 hours, and this drug is sitting at the FDA and hopefully will be approved before the end of the year. That is the goal. So FRESCO-2 was an international phase 3 study that I had the pleasure of leading as the senior investigator with my colleague, Dr. Arvind Dasari. This was in metastatic colorectal carcinoma patients. So what is fruquintinib? Fruquintinib is already FDA approved in China. It is an oral, highly selective drug specifically for VEGF family pathway. What is the VEGF family pathway? A tumor needs a blood supply to grow and spread. Bevacizumab, as many of you are familiar with, blocks one receptor, VEGF-A, and then this drug blocks specifically the receptors 1, 2, and 3. So it's very selective, and it has a single agent. It was evaluated as a single agent. So this was the study design. It's 3 weeks on, 1 week off. It was compared versus best supportive care. And I know not necessarily everybody was in favor of that originally, but the purpose of that is because at the time that we opened the trial, there was no other standard of care in that setting. And we did not want to exclude any patients. So we allowed patients not only that have received prior TAS-102, patients may have received prior regorafenib, and then also patients may have received both of those drugs as well. So at the time we opened up this trial, there was no other phase 3 clinical trial at that time, and we did not want to exclude patients. We wanted to give all patients the opportunity to go on this drug, on this trial. And it was a 2-to-1 randomization. The primary endpoint was overall survival. And basically, what do you need to know? This is an international study. I do want you to note that the slides have since been updated. We said that actually it was 5 prior lines of therapy patients had received. That is not the case. In fact, it is only 4 prior lines of therapy. Unfortunately, when we presented ESMO, they included adjuvant chemotherapy, and it should not include adjuvant chemotherapy. 4 prior lines of disease from metastatic disease. Half of the patients in both arms had received prior TAS-102, and this is before the Sunlight data came out. So this was just simply TAS-102. They could have received bevacizumab, but once again, outside the United States, that was not common at the time. And as you know, that's why Sunlight was created, primarily for those outside the United States. And then about 40% in both arms were exposed to both drugs. This is the primary endpoint of overall survival, so a difference of 2.6 months. And what is really noticeable here is there's a huge splay, meaning there's a clear difference between the 2 curves in favor of fruquintinib. And basically all across the board for every characteristic was in favor of fruquintinib. For overall survival, also the curves clearly separated in favor of fruquintinib for overall survival. And oops, I'm sorry, I had duplicate. The main side effects we updated this year's ASCO, so I wanted to throw in this slide. This was my poster. So about 14% of patients had grade 3 hypertension, meaning that, and once again, it's a class effect for this drug. Almost everybody ends up with hypertension, and about 30 to 50% of patients roughly as a class effect with bevacizumab, regorafenib, et cetera. So 14% of patients did have hypertension, but in regards to how many of those patients required a dose reduction or dose discontinuation, less than 1% across the board. And so hypertension is the main side effect. Hand-foot syndrome does happen in less than 7% of patients, but that is not the reason that anybody really resulted in a dose reduction or for any reason coming off study. So overall, tolerated extremely well. Basically, this is a single agent, oral agent, 3 weeks on, 1 week off, that appears to provide benefit for disease-free survival and overall survival, with excellent tolerance to treatment, excluding main toxicities, hypertension, and some hand-foot syndrome. But very rarely did it ever cause patients to discontinue therapy. Okay. I'm just going to try to hurry this up so we can get some questions, so I apologize. So as many of you know, there's a lot of interest in early onset colorectal cancer. That's a special interest of mine. Eric Lander is my second-year fellow who I have the pleasure of mentoring, and we decided to look at the database with our colleagues in Natera in regards to circulating tumor DNA. So I won't show the data because I know many of you in the audience are fully aware of this, the rising concerns of early onset colorectal cancer. But prior studies have been conducted, and what we wanted to do is look for unique driver mutations specific to early onset colorectal cancer. And so this was a total of 13,000 plus patients. This was only in stage 1 through 3. We did not include stage 4 at the time of this presentation to reduce the heterogeneity. What we decided to do is look at those that were less than 50 and those that were greater than 60. We did not look at the group between 50 and 60. And you'll see 16% of those were considered early onset. Average age onset patients were 54% of our patient population. And as expected, the majority of patients were rectal carcinoma patients for early onset. This is the breakdown by stage. As you can see here, the majority were stage 3. What are the findings? So the findings were that there was a very select number of patients that were surprisingly microsatellite stable, so did not have the inherited form of colorectal cancer, but had a high mutation burden, which has not been reported previously in the early onset patient population. Once again, small numbers, but still a fair amount. So your MSI stable, TMB high patient population here is in green. So more so in the colon patient population than in the rectal patient population. Other key findings, just so you are aware, we did look at other standard kind of molecular alterations, and they were very comparable to what's been reported in other studies. So that was not unique. But other aspects that we found to be unique in our MSI high, TMB high patient population, we actually noticed there was increased expression of HER2 or ERB2, as it's noted scientifically, and ERB3, which has not been reported. And we don't commonly test for HER2 testing in early stage patients. So this was obviously of great interest as well. And then in our MSI stable TMB high patients, we did notice an increased incidence of POL-E mutations. But once again, and many of you may be familiar, POL-E mutations may potentially benefit for immunotherapy. What does this signify? Overall, these were the key genomic differences in our patient population. So in our MSI high, TMB high patients, we noticed more ERB2, ERB3, or HER2, HER3 mutations. And then in our MSI stable TMB high patients, which has not been reported thus far, once again, most of these patients were early onset colon patients. They had more POL mutations, which suggests they may benefit from immune checkpoint inhibition. So this is more hypothesis generating. And basically what I would like to signify is that this indicates that for our early onset patients, even if they do not have metastatic disease at presentation, I would highly encourage next generation sequencing to be completed so we can differentiate some of this data, because obviously HER2 has never been evaluated, as far as I'm aware of, in early or locally advanced disease. And then the previous data that's been reported regarding the use of pembrolizumab in TMB high patients, there were no colon cancer patients in that original study. So some things to keep in mind. And last but not least, and I always show this because this was one of my best friends who was your patient advocate for fight colorectal cancer. And I just always try to acknowledge her whenever I can, because she was an amazing individual and she really influences me to this day. And I still talk to her husband regularly about what can be accomplished if you're motivated and how much you can really inspire others. So thank you so much for your attention. And I'm so sorry. I know it's a lot of information, so I'm happy to take questions. And How do I stop sharing? Pause share, stop share.
Thank you,
Okay.
Dr. I have to say that was very, very informative and I appreciate all of the time you put into that. That was a really informative presentation. There are a few questions and I have some questions as well. So what I'm going to do is I'm going to go through the questions that are in the Q&A first. And if we have time at the end, then I will ask my questions.
Sure.
I have one here. It says, hello, I'm very interested to know if there were any trials or research discussed at ASCO that discussed using immunotherapy for MSS CRC patients with or without KRAS, BRAF, HER2 mutations.
There are, there's several small studies that are trying to look at ways of how to incorporate immunotherapy in the MSI stable patient population. There is a large trial that is ongoing from Agenesis looking at the non-hepatic metastatic and non-peritoneal metastatic patient population that is has opened at some sites. It is a national trial, and we are. In full disclosure, we are one of those sites that are participating in this trial. And that is looking at combined immunotherapy in the non-liver and non-peritoneal stage 4 patient population. So yes, there are trials, but it wasn't necessarily reported at ASCO. It's actually been reported at last year's ESMO.
Okay, so the next question I have here is from, my screen is jumping around here,
Okay.
is from Kurt. He says, Dr. Eng, during study, were you aware of any patients who were candidates for advanced nerve sparing wand, in quotes, technology to help preserve sexual function regarding nerves, male and female, in and around the rectum? If so, were they included or excluded from the prospect trial?
So I am unaware of that terminology. Nerve sparing wand, is that a certain, it sounds like it's a certain technique. For the prospect trial, the radiation therapy was standard either external beam or intensity modulated radiation therapy, so toned down radiation therapy, which is pretty standard radiation treatment for the rectal cancer setting. So I am unaware of any of those patients specifically to the apparatus he's discussing.
Okay, Kurt, we'll look for you to explain what that technology is. I have a question here from Annie. Annie says, it seems like there is a lot of important choices that just diagnosed rectal patients have to grapple with, and with quality of life issues. How could a newly diagnosed rectal patient deal with all of these choices?
Yeah, no, great question from Annie. As I mentioned earlier, there's so much data that you can incorporate from each of the rectal cancer trials. And so it's really, I think the most important thing is to have a good healthcare provider that you feel that you are having the ability to communicate your concerns. And, you have to discuss, number one, you have to take into account where the tumor lies anatomically, the number of lymph nodes that are involved, as well as you want to talk about, depending upon your age or depending upon whether or not you're concerned about fertility preservation or sphincter preservation. I think all those different factors do have to be taken into account. And then obviously sexual, bladder, and urinary dysfunction also needs to be taken into account. Every single one of those trials has unique characteristics. And so that's what's extremely important. And once again, it may sound biased, but I'm not trying to be biased. I'm trying to say, if you're a patient with rectal cancer, I would highly recommend, if you cannot go to an academic institution that is very familiar with these trials, like I know almost all the rectal cancer trials by heart. And so, they all have different characteristics, and you want somebody that will partner with you on that. We understand that radiation therapy, if you must undergo radiation therapy, is time consuming, Monday through Friday for 5 weeks. But I always try to remind patients that it's 5 weeks to really change their life. And potentially in the case of sphincter preservation, that's obviously very, very important. Nothing is wrong with getting a second opinion. If you live in the community or you don't have access to a academic institution, just go for a second opinion to see what your options are.
Okay, Kurt came back with, so I'm just going to say, he said that is originally a prostate cancer tool in surgery. So that was his definition.
I do not treat prostate cancer. So, and I'm definitely not a surgeon, although I feel like sometimes I have the personality of one. But I am unfamiliar with that. And then obviously it becomes much more complicated when you have a history of prostate cancer and you've received prior radiation therapy, and then you have rectal cancer. That's a whole other story.
So this question is from an anonymous attendee, and I'm going to murder the name of this drug, so forgive me. It was the last drug that you talked about.
Fruquintinib.
Yes, is another drug that only extends our lives by a few months. When can we start to see trials that provide more durable responses? And I'm just going to piggyback on that question because I had a question on this as well. Do they have biomarkers that are testing specifically for VEGF 1, 2, and 3? You said bevacizumab deals with A, so how are we determining which? And I realize this drug has not been approved by the FDA, but just, you know, if we're looking at a targeted therapy.
So it's not about VEGF expression. Avastin is not based upon VEGF expression.
Okay.
It's just capturing that target. So speaking about molecular markers regarding any anti-VEGF therapy, none of them have been beneficial. Thousands of dollars have been spent on Avastin studies trying to see if there's any particular patient population. Thousands of dollars have been spent on regorafenib to see if there's any patient population with the VEGF therapies. For the most part, there have been no biomarkers that have been identified thus far in any anti-VEGF phase 3 clinical trial to date. And unfortunately, when we open up Fresco, it was during COVID. So what I should mention is that we completed this trial in record time despite during COVID. And so that was the unmet need. And unfortunately, during COVID, we had a supply chain issue. So we actually had all these molecular markers for circulating tumor DNA, and we could not get our tubes to all the sites. And so we just gave up because we could not get the supply that we needed for molecular analysis. But historically, none of the prior trials have demonstrated any specific molecular markers specific to demonstrating benefit of therapy for anti-VEGF therapy. Going back to the question regarding fruquintinib, you may think that it is only a few months of benefit, but the reality is that was we allowed all patients to participate in the trial. So that's why it appears to be a heavily pretreated patient population. These are patients that received 4 prior lines of therapy. So unfortunately, it comes across like it's not a good thing that it's a heavily pretreated patient population, but it was partially in part because that's what I was trying to accomplish. So I could offer therapy to patients because I knew there was no standard of care. So could I be like Sunlight and they only looked at the 3rd line patient population in Europe? Sure, we could have done that, but then we would have omitted a lot of patients that needed therapy at that time. As I stated earlier, we were the only phase 3 trial at that time. And keep in mind, that is a median, and there are patients that clearly exceed that. So whenever people say, oh, it's only a few months, well, that's a median. There are 50% before and 50% after. And that's what I kindly remind people. And don't forget, this was as a single agent. It has not even been looked at yet, at least in a larger study patient population with various combinations, and it's an oral agent. So every single drug that we look at that gets FDA approved provides some benefit to patients. And I think it's really important to keep in mind because we have our limitations for surgically unresectable patients, and we want to offer all therapies available to them as long as their labs look good, as long as they feel well. So I'm very, very, I get a lot of patients that are very negative at first, and I'm like, no, but look where we are. I mean, if you get no therapy, the survival is 4 to 6 months. We are now exceeding way past 3 years, headed hopefully more towards 4 years for our median survival for surgically unresectable patients. So I think it's really important to keep those things in perspective. And please participate in trials. We cannot get breakthroughs. In the United States, less than 10% of patients participate in clinical trials. This is a huge problem with the system as patients don't participate number one, I know it's hard. It's not necessarily convenient. But number two, some sites don't open up the trials that patients need as well. And number three, as Fong knows, help. I'm very, very passionate about the fact that, and federally funded trials may be the most beneficial trials, but the federal funded studies do not reimburse the sites as well as pharmaceutical sponsored studies. And even pharmaceutical sponsored trials are largely now going overseas because it is more inexpensive, which sounds horrible. And they can enroll faster.
We're at our 2 o'clock, so I'm just going to ask one more question related to the same drug. Is it expected that this particular drug, I'm not going to try the name again, would work
For
after?
quit to
Thank
death.
you. I'm not even going to, I know I'm going to murder it and I don't even want to do it. Do you expect that may work in patients after bevacizumab?
Oh, no. That's a very good question. So 90+% of our patients have received prior bevacizumab versus the Sunlight trial, which actually 26% of patients, because it was conducted largely in Europe, had never received prior bevacizumab. And if you actually look at the curves and depending upon the prior bevacizumab exposure, it's better for those that had not received prior bevacizumab in the Sunlight study. For our patient population, we required patients to have been exposed to it, and 90+% of patients hadn't received prior bevacizumab.
If I can, just one
Great
more.
question.
One more comment here. This comes
Sure.
from Adelina. She says, hi, thanks so much for the summarization on key findings of bowel cancer. How do the possibilities look for receiving this drug? Living in Sweden, where my mom has stage 4 bowel cancer and is currently on Lonsurf and bevacizumab. Thank you.
She's asking about fruquintinib. Yeah,
Yes.
so I should mention that. Great question. And thank you for calling from afar and watching this from afar. Our application, first and foremost, is going to the FDA, which is already in there. Second of all, it's going to the EMA. And third of all, it's going to Japan. So the approval intent is international worldwide approval because it's already approved in China. So the goal is worldwide approval.
Perfect. I still have some questions here. I'm going to leave this up to the FIGHT CRC staff if we want to go on. I know we're at our time limit right now. So there you go. Thank you so much, Dr. Ng.
Thank you, Julie. Thank you. So with that, I know we do have a couple more questions and I want to be sensitive of Dr. Ng's time. So I have captured those questions. I can leave it up to you, Dr. Ng, if you would like to answer them now, or I can send them to you via email and I can.
I have a couple more minutes. I'll just let them know.
Okay, so this comes from Annie. It says for ADC for her 2 patients, for people with lung mets, are there more issues of interstitial lung side effects? We've seen that is one of the side effects with adjuvant drug conjugates. So just a question there. Lung mets increase.
Yeah, great question. That has not been definitively determined. It is a great question, but there has been no specific causality thus far that's been determined to be associated with interstitial lung disease. There seems to be a little hint, maybe a little bit more in the higher dose based upon that small study, but historically, based upon the breast and the gastric data, there's not a specific factor that they can identify.
So, and then Kurt came back and said, last note here for the rector, Dr. Peter Carroll, he's a legend of USFC, can advise top rectal cancer surgeons at academic settings how to possibly incorporate this nerve-sparing wand to help quality of life and post-surgical patient rectal cancer surgery issues. So just a comment from Kurt on that. And then Sarah has a comment too. I know dozens of patients that want to enroll in clinical trials and are out on waiting lists. Do you want to speak to that quickly?
I suspect if waiting lists would largely be for phase 1 trials, I would presume. There's usually not waiting lists for phase 2, phase 3 trials. Waiting lists would be because they're small cohorts of patients for phase 1 trials. So.
Okay, last question that I have here again is from an anonymous attendee. Is I'm going to do it again, expected to be more effective overall than Avastin in terms of overall survival?
Well, Avastin does not have great activity by itself. It was looked at originally in trials when I was in training. It works best with chemotherapy. We do not give Avastin by itself, so I think it's important to keep in mind. Are we going to do like a head-to-head comparison in the frontline setting? That would have to be in combination with treatment for Avastin. And then obviously that would have to be in combination with fruquintinib, I would presume, to have a more comparable head-to-head comparison. But bevacizumab / Avastin does not work by itself. It has to be with 5FU based therapy.
Okay. I just have a quick question. I saw you present something on the Prodigy trial and you said cancer-specific survival. I had not seen that term before. Can you explain
Yeah.
it?
Cancer-specific survival, instead of overall survival, they could have passed away for some other comorbidity. Cancer-specific survival would be specifically to cancer in and of itself, due to cancer in and of itself.
All right, perfect. And then you talked about Janice as kind of, which was my other question, the de-escalation that they showed worked well in Prospect. Would that be carried over, or perhaps carried over, considering you had complete responses in small number of patients, but still had them? Would that be appropriate in the watch and wait setting or the Janice trial setting? So
yeah, so the Janice trial does take into account the consideration that there may be patients that are interested, obviously, in a sphincter preservation approach. Yes.
okay. Those are my questions, and that answers all of the questions that came in the Q&A. So again, I want to thank Dr. Eng for just a wonderful presentation today, and it was very, very informative. Thank you.
Well, thank you so much. Sorry, I know it's a lot of data, even though it's only, it's less than 10 abstracts, but they're quite different. So
yes, they were, and they produced a lot of data. So you did a fantastic job summarizing. Thank you.
Thank you so much for your time.
Thank you both so much. Keep your eyes on your emails. The recordings of this will be available in the next few days. And I just want to thank Dr. Eng again and Julie again for taking the time out to present with us. It has been so informative, and we are just so honored to have you here. So thank you, and I hope you have a great rest of your day.